he got it. So again, a huge welcome to Dr. Heather Beach. She grew up in New England as a horse crazy kid, showed in dressage, jumpers, and even some eventing before she started a career in veterinary medicine. Graduating from Tufts University in 2007, she's continued to have her love for the horse and the equestrian sports guide her career. She founded HB Equine Services in 2022 and provides high-quality sports medicine diagnostics and treatments to her clients. Dr. Beach can often be seen helping her partner, JJ Lavieri, at horse shows, setting jumps, grooming the horses, as well as taking care of their healthcare needs. She competes in dressage and in jumping, and also enjoys bringing along young horses and ponies for resale. So I'm going to, without further ado, turn it over to Dr. Beach. Welcome.
Thank you guys for having me. So we'll try to get the slides up here. When Susan asked me to participate in this and gave me my topic, I thought, oh, that sounds great. That's easy. The horse's head. That's such a limited area of the horse. I can certainly do a 1-hour talk on that. And then I started putting the talk together and I thought, oh my goodness, there is a lot of anatomy and a lot of function inside the horse's head. So I did my best. This is not exhaustive. I don't have everything that could possibly go wrong in a horse's head in here. I don't even think I have everything that could be normal in a horse's head in here, but I tried to pick out the big topics and a lot of the clinically relevant things, especially for the dressage discipline. So if I missed anything, please don't be mad at me. Shoot me an email, ask me questions, and happy to talk about it at any point. So actually I need to see if I can move us out of the corner here because I can't see my slides that good. Perfect. So basically the way I structured the talk is that we're going to kind of go system by system within the head. There are, a lot of these systems kind of overlap and the anatomy will overlap, but overall I'm categorizing it into the ocular system, the vision, the eye, and what goes into that, the parts of the anatomy that are dealing with the respiratory tract, the nervous system, the specific functional anatomy there, as well as the gastrointestinal system. And then at the end, I guess I could have done a separate section on musculoskeletal. That probably would have been a little dense. So everywhere, at every stop, the musculoskeletal system kind of plays in a role in this. So we'll just sort of touch on that as we're going. So it's really important to know the anatomy, and hopefully with some of the photos and some of the descriptions that I'm talking about, you'll get a sense, just a better feel for the anatomy of the horse's head, because this is really important for you to understand whether or not there's something abnormal that's important that requires a vet call right away. And also what I think is really important for everybody who rides a horse and tacks a horse up every day is that the tack is fitting properly and not interfering with an important part of the anatomy. And then if you're having a problem with your horse and you need to troubleshoot some kind of performance related issue, if you sort of know the anatomy and the function of the head, this can help you, either understand what the professionals are telling you better, or maybe eliminate the need for a second professional and help you make good choices about your tack and things like that. So again, just to reiterate, we're going to be looking at this from a system-wide perspective. The ocular system, which includes the eyes, eyelids, eyelashes, the nasolacrimal duct, the tear duct, the nervous system, including the brain stem, the cranial nerves that, operate everything inside the head. Respiratory system includes the larynx, the pharynx, the nostrils, the guttural pouches. We'll get into a little bit more about what that actually is, sinuses, and the digestive system, including the tongue, the teeth, the esophagus, and again, the palate will be part of that as well too. So, whoa, big slide, lots of words, lots of anatomy. Just the eyeball itself is pretty extensive. So, maybe if you didn't go to vet school or you haven't had biology or an anatomy class, the anatomy of the eye, you don't know how complicated it really is. But this is just a overview of what the anatomy of the eye entails. Externally, you're going to have the eyelids. The third eyelid on this little picture, it's hiding back here, but that's that little pink thing that comes up from the corner of the eye. We call it the windshield washer for the surface of the eye. So sometimes they'll flash it. It'll come up and flash over the cornea and just sort of wipe away any debris that's there. And it can be a protective, another layer of protection for the cornea and for the eye, just as a anatomical structure. The conjunctiva is this was hard for me to understand when I was in vet school exactly what it was. So the sclera is the whites of the eye, the white part of the eye, and then there's a thin layer over the top of that, which is the conjunctiva. And so we've all heard of conjunctivitis. Probably we've all had it at some point in our lives, where your eyes get really crusty and stuck together and maybe a little bit puffy. We've all seen a horse that has a really red eye. And so it's not the eyeball itself that's red in that scenario, it's the conjunctiva. So that's just a lining that covers the sclera. It goes underneath the eyelid, it covers this undersurface of the eyelid, and then covers the external part of the sclera here. And that will get very inflamed when the eye itself is inflamed. So that's what's going to be red when you have a red eye most of the time. Then you have the lacrimal duct, which is the tear duct that produces the tears. It's important. Tear function is really important to keep the eye healthy. And then on the eyeball itself, like I said, we have the sclera, which is the whites of the eye, the cornea, which is the clear outer surface of the eye. So that's translucent. You shouldn't be able to see the cornea. When you can see the cornea, that's abnormal. The uvea, which is composed of the iris and the ciliary body, that's the colored part of the eye. So, whether it's the brown part or the blue part, if it's a blue-eyed horse, that's the part of the eye when you look in it that has the color. And then the hole that is formed by the colored part of the eye, that's the pupil. That's where the light goes through. Then behind the pupil is this big round structure that is called the lens. In humans, the lens is really important, and these little ciliary bodies that attach to it are really important. So because we have such good vision and like we can read and things, then the lens will actually do a lot more to focus the light and refract the light for near versus far vision, and change where on the back of our eye the things come into focus for that purpose. Probably in horses it's not quite as important. There's not as much function of the lens, but this is where cataracts form. So if there's any damage to the lens, it's not going to be clear. The light can't go through. There'll be a cataract on it, and it blocks the light from getting to the back of the eye. And so the back of the eye, this choroid or retina in the back of the eye, that's where basically the signal from the light gets translated to the nerve, the optic nerve that goes to the brain, that tells your brain what you saw. So I think that's on the next slide. Basically, the whole point of vision in any species is it's a translation of light signals and photons. So those photons need to get through the outside of the eye, past, through the pupil, past the lens, and they need to hit the retina. And then the nerve, the optic nerve, needs to be able to send that signal to the brain. And then the brain has to recognize whatever it saw and give you the perception of vision. That's how the whole system works. So if any part of that breaks down, whether you have you could have a lesion on your brain that made you unable to recognize light anymore, and your eye could work perfectly, but you would be blind that way. They call that cortical blindness, when the blindness comes from the brain. You could have a perfectly functional eye, but damage to your optic nerve, and then you wouldn't be able to see. Or you could have anything that blocks the light from getting through the eye, so that the light can't hit the retina properly, and that will cause vision loss as well too. So basically anything that blocks light will block vision. Scars on the cornea, masses on the iris. I forgot to put in a picture of a corpora nigrans, a normal corpora nigrans. That's those little things that are on the edge of the iris. on the edge of the pupil that are normal most of the time, but sometimes they can be enlarged and they can block vision. So a corpora nigrans cyst is a common finding that we might find like on a pre-purchase exam or during a regular physical exam. And that just looks like a little ball kind of hanging on the side of the horse's eye. And usually they're not harmful, but if they start blocking vision, they can cause symptoms. And we'll get into what the symptoms could be. So like we said, cataracts on the lens will block the light from getting through. Inflammation within the fluids of the eye. So there's fluid inside the eye, and if there's a lot of inflammation, then that will refract the light differently. And then obviously damage to the retina or the optic nerve would make it so the horse would not be visual. So symptoms of ocular problems. The most common is going to be squinting, tearing, swollen lids, like this little pony has here. If you go out and you see your horse holding its eye like this and it's swollen, a lot of times people say, oh, he bumped his eye. And usually that's actually not the case. So if you have a horse or a pony whose eye looks like this is technically a veterinary emergency. Now your vet may be able to talk you through it, a little first aid for it for 24 hours or so, depending on their schedule. And depending on what you tell them, but in reality an eye like this needs to be seen, because when I did go out to see this one, you can see this green spot here. This is the dye that we put in to look for a corneal ulcer, and that's what this pony had going on. He got a piece of sand or something in his eye and scratched his cornea, and that's what was causing the pain. So all this redness up here, remember when we were talking about conjunctiva, that's conjunctival swelling and redness, and that's just a reaction to the inflammation caused by the corneal ulcer, and then the pain, and the squinting and the pain is caused by that. This is a very superficial ulcer. This is super easy to treat. You're going to give them a little bit of triple antibiotic ointment, some Banamine for the swelling and the pain, and this will heal up just fine. However, if you don't get prompt veterinary treatment for this, or you treat it with the wrong thing, then this can get infected. You can get a fungal infection in there. You can lose the eye over a corneal ulcer. So that's why I like to reiterate that this is a big emergency. It's not a panic emergency, but this is don't wait and see. Don't just say he bumped his eye, put an ice pack on it, and not have it seen, not have it stained. These need to be stained. So additionally, a condition called uveitis, which is just pure inflammation of the eye, will also look like this. So that's where the vet coming out to stain to see, is there a scratch or is there something else going on, is really important, because the two treatments are completely different. For uveitis, you're going to put a corticosteroid in there like dexamethasone, and that's going to help with the inflammation. But that also, those corticosteroids also suppress the immune system. So they would make, if you put corticosteroids on an ulcer, you're going to make it much more likely to become an infected ulcer, or especially even worse, a fungally infected ulcer. And those are very difficult to heal, and you can lose the eye over that. So big important take home message is eyes are not something to mess around with on your own. And that's definitely worth a vet call and should be seen probably within 24 hours at the latest. So symptoms of a horse with vision problems. So let's say that externally the horse's eye looks to you to be normal. If you have a horse that's demonstrating some clumsy behavior, self-trauma, like maybe bumping their head, they can also be a little bit bullied in a herd situation because they're just not visually picking up on the cues from their other herd mates. So they may, maybe low on the totem pole. Spooking and head shaking, those are all, if you have a particular problem with a horse with this, definitely have the eyes looked at. It's generally speaking, a pretty easy way to rule in or out a vision problem. I can think of a horse that I knew that was a very sweet horse. She was very willing, and she was very willing to jump the jumps, but she really had to, there are horses that have a peek at the jump. They need to kind of look at it and study it first. And this one had a really hard peek the first time she jumped a jump. She was willing to jump it. She wasn't spooky about it. She wasn't saying no, but she really had to study it the first time and then was okay. And that horse had really pretty advanced cataracts when she was ultimately examined. So they don't have to have, big, dramatic, I'm not performing kind of symptoms. They can still be somewhat subtle and still be fairly affected. And then head shaking, basically this entire discussion, everything we talk about could be a cause for head shaking. So, that's a big problem for some horses. And we'll talk a little bit about the one where you don't really find anything wrong, but they still have this head shaking problem. There is a syndrome of that's called a head shaker syndrome. But remember that you need to be ruling out all of these other things that could be wrong, because anything that goes wrong in the head could cause them to become a head shaker, basically. So with that, we'll leave the eyeballs alone a little bit and we'll move into the nervous system. Basically the central command for the horse's nervous system is in the head. That's the brain. The brain of the horse is fairly small compared to their overall head. This is not really a life-size drawing, but most of the horse's skull is air and sinus. There's a very small amount of it that's actual brain. Not that they're not smart, but they don't have huge brains up there. So the brain stem is the central place for function. Basically, the horse's respiratory system is there, and that's where all of those cranial nerves are going to come out of the brain. So those are the things we're going to get more into what the cranial nerves are in the next couple of slides, but they all come off the brain stem. The cerebrum is the center of conscious decision making. So whatever consciousness that a horse has, it's coming from their cerebrum. Obviously in humans, that's the part of our brain that's very advanced and very enlarged compared to other species. And that's what makes us special. And then the cerebellum, which is towards the back of the brain, right above the brainstem, that's going to be involved. That part of the brain works for movement and coordination and motor control. So if you have a horse actually that has shivers, I don't know if you've ever seen that, but those are horses that really hike their hind legs up really high. Most of the more recent data studies have proven that to be a cerebellar problem. So some kind of degeneration in the cerebellum of the brain. Horses, or actually kittens, there's a disease called cerebellar hypoplasia, where they just don't have that much cerebellar tissue, and they're hypermetric. They kind of step really big with their legs, and they're kind of cute in their sad little way. They're very uncoordinated with big stepping movement. So that's, if you had a problem with the cerebellum, think that. High stepping, goose stepping behavior, shivers, that kind of thing. And then the peripheral nervous system in the head is going to be the cranial nerves. There's actually 12 cranial nerves. If you go to vet school, you have to learn all of them. There's a mnemonic for it. You guys don't need to know about it. We're going to talk about a couple of them that are relevant. So cranial nerve 5, which is the trigeminal nerve. And I apologize because this photo actually doesn't show the trigeminal nerve at all. This is really showing the facial nerve. So the trigeminal nerve, do you all see my my marker when I'm moving it there, the cursor? Okay, good. So the trigeminal nerve is part of it is going to be under here. It comes off the brain stem, and it's a 3-branched thing. So one of the branches is going to go to the ophthalmic nerve, and it's going to be sensory to the eye. So nerves can both be sensory or motor. Sensory means feeling. So these are the nerves that bring you the sensation. Motor, it means function, like it's going to make a muscle twitch. So the trigeminal nerve is mostly 90% a sensory nerve. So sensations from the eye, not the optic nerve. So cranial nerve 2 is the optic nerve. That's the one that's actually bringing the photons to the brain to say, did I see things? But the cranial nerve 5 sensory says, do I feel something on the surface of my cornea? Does my eyeball hurt or not? That's what 5 does. And then it comes out this foramen here in the skull, and that's the maxillary nerve branch. So that's within the infraorbital canal in here, and that gives you sensory to the face and the upper jaw. So all the lining inside the nose and the nostrils, and then the skin sensation on the face is coming from there. And then the mandibular nerve is a third branch, and that's going to do the mandible down here, the lower part of the jaw. So this is sort of the, the big thing that we think about with actual head shaking syndrome is that there can be like a trigeminal neuralgia, so actual inflammation of the nerve, irritation of the nerve. We don't really know why. It's a not well explained thing, but horses that have this, that have head shaking, like true head shaking syndrome caused by the trigeminal nerve, it can be very severe, and it can cause what seems to be uncontrollable head shaking, compulsive nose rubbing. Now, every Lusitano I've ever met in my life rubs its nose on its leg. So I don't think every Lusitano on earth has head shaking syndrome, but you'll see them kind of like compulsively just, you stop riding and then they rub. A true head shaker is going to be worse in bright light most of the time. I am a phototic sneezer. If I go out into the sun, I sneeze. So I think it's a little bit of that sensation of, I guess not everybody has this, but for me, I have it all the time. So a little bit of a tickling feeling, and I think it can go all the way up to painful. A lot of times they are worse when they're ridden versus at rest, but some of them will do it at rest too. These nose nets are useful. So what they're doing with the nose net is you're just blocking the air from flowing through their nostrils, giving a little bit of a windbreak and some kind of a sensory block or something to try to just almost distract the nerve from the signal. There are all sorts of medications and acupuncture, and I have done steroid and Serapin injections into the infraorbital canal to try to treat some of these horses. Generally speaking, though, it's a poor prognosis, especially for a competition horse, because a lot of the medications that you can use for it are restricted in competition. And obviously, if they're having a relapse and they're shaking their head all over the place, they're not going to do well in competition as well. So this is a sad problem for some horses, and it can be performance limiting. And then there have been cases of horses that had to be put to sleep because they're so severely affected. But the one thing I hope you know is that this is a real thing, but you have to rule out all the other reasons that the horse could have a problem in their head, because there are fixable reasons, and there are other things besides just this weird nerve problem that the horses deserve to have the workup to rule out all the other things. And it is a process of elimination. These things are not anything that's going on inside the head is not going to necessarily be easy to diagnose. It may take some advanced imaging. So the next cranial nerve I want to talk about is cranial nerve 7, the facial nerve, and that is showing up here in this picture. So the facial nerve is very superficial on their head. You can see it runs right here, basically where the halter buckle would be. So there, one of the things we're taught as veterinarians is if we're going to do surgery on a horse, like say we're going to lay a horse down for a castration, even that short amount of time, you always unbuckle the halter, get the halter off of the side of their face, because just laying on a hard buckle against this nerve, the compression of that hard buckle against the nerve and the weight of their head on it can cause facial paralysis. And that can be permanent, it can be temporary, but it can be permanent too if there's too much damage that happens there. So that's a consideration for bridle fit. There's all sorts of anatomical bridles out there now. They're trying to avoid all these trigger points and all these, delicate nerves and things like that. My personal opinion is that if the horse doesn't have a specific problem and the bridle is, quality enough and fitting well enough, and we're not cranking that crank nose band as tight as we can get it, because we have holes in our training and things like that, then I don't think that every horse needs an anatomical bridle, but if it is something to play around with and to try if you're having a problem that seems to be head related. And again, I'll also reiterate that I think a lot of the problems that we see in the head are coming from somewhere else in the horse too. That's the other part that makes it confusing. It can be the hands of the rider, it can be the saddle fit, it can be the diet of the horse, it can be everything. So we always have to be realistic with ourselves and look at ourselves first. I think we look at ourselves as riders first, we look at our tack fit second, to make sure, try to make sure we're not causing any problems. And then we got to rule out all other sources of discomfort that are expressing themselves to the head. And then, but also obviously we do owe it to the horses to look into problems in the head if we really feel that that's where it's coming from. So again, this is relevant for bridle fit and tack fit, knowing that these nerves are running very superficially on the side of the face. So, oops, hang on, sorry. So the facial nerve, the cranial nerve 7, also gets involved with a stylohyoid bone fracture. So deep inside here is a structure called the guttural pouch. And the guttural pouch is an outpouching of the horse's eustachian tube. We don't have these, we just have the normal eustachian tube. If anybody had ear infections when they were a kid and had to have tubes put in their ear, that's where they put them. It kind of goes from the base of the ear and opens into the pharynx. And in horses, there's a big pouch. And the bones, I think I have that on. Yes. So this is what it looks like inside the guttural pouch of a horse. This bone right here is the stylohyoid bone. There are vessels. The internal carotid artery lives inside here, and then there are little nerves, cranial nerve 7 being the big one, that runs through here. So if this bone gets fractured, oftentimes you'll have damage to cranial nerve 7. And this horse is showing symptoms of cranial nerve 7 damage on the left side. So the ear is droopy, the nostril is droopy. They lose their ability to blink, actually. So they lose the motor to the eye, so they can't blink. They'll often get corneal ulcers. This picture down here, this is an arthritic stylohyoid bone. So normally it should be small and smooth, just like this. Actually, Susan, you'll like to know that this is Carol King's stylohyoid bone. The day that I had to try to figure out what was wrong with her, that was my boyfriend's horse was having a problem, and I had to scope her to make sure she didn't have this going on. She was fine. She's fine. Everything's fine. And there was nothing wrong with her. But this is a picture of her stylohyoid bone for me to make sure. So this horse has an arthritic connection there. So they can have arthritis of this joint, big bony proliferation, and they might not be as dramatically affected as if they had an actual fracture there. But they can be violently painful, very resistant to contact, strange symptoms. And so this is certainly, it's a bit invasive and takes a little bit of work to diagnose this, because you have to go, endoscopically get into the pouch and then look at this. It's very difficult to diagnose on a regular x-ray because so many things overlap in the head. You can try to get a sense of it from an x-ray, but really scoping is going to be the gold standard way of diagnosing this before you get to a head CT, which is going to be the next best diagnostic. So again, a horse that has temporohyoid osteoarthropathy, meaning the arthritic condition here, you might have pain when you apply pressure to the base of the ear or the throat latch, head shaking, head tossing, reluctance to accept the bit or perform under saddle in specific head positions. And then when it becomes more advanced or it fractures, because that's what ultimately can happen, it fractures, they'll become profoundly ataxic, so neurological. They'll have the lip and the ear droop, head tilt, difficulty swallowing and or blinking. And those symptoms are related to the cranial nerve 7. This bone and this articulation moves when the horse chews and swallows. So actually the cure for this is a surgical procedure where they actually just cut the connection of the muscle from the base of the tongue that moves the hyoid apparatus. It's called a ceratohyoidectomy. And that can bring relief and function back to a lot of these horses. So it's an interesting thing, and it's important to know that it exists, because if you know have this happen to your horse, it can, the symptoms look so bizarre all of a sudden, and it can be very confusing. But it can be a somewhat straightforward diagnosis if you know what to look for. Okay, so from there we'll move into the respiratory system. Um, So the horses, a lot of the head is going to be airway, like I said before. This picture here is kind of showing all the different sinuses. So most of your horse's skull here is just going to be air in this frontal sinus. These two down here is going to, on each side, you have the rostral maxillary sinus and the caudal maxillary sinus. And these, you know, the teeth of the horse will, the tooth roots enter into these sinuses. And so that's where if you have like a tooth root abscess, you might get an infection into these sinuses here on the side of the horse's head. Airflow goes in through the nostrils, through this nasal septum. This is where it's kind of warmed and humidified before it goes back into the upper, you know, the part of the nasopharynx here, and then before it gets into the trachea. Let's see. Horses are obligate nasal breathers, meaning that they cannot breathe through their mouths unless they happen to displace their soft palate. So, but basically, you shouldn't really think of that because they're not supposed to have a displaced soft palate. So basically, they have to breathe through their nose. Anything, just like anything that blocks the light getting to the retina can affect the vision. Anything that reduces the ability of the air to flow to the trachea and into the lungs will reduce airflow. The good news for horses, though, is they are such wonderful athletes. They have such a great respiratory capacity that for 90% of our performance horses, having a little bit of an airway obstruction is not going to make them symptomatic. Horses that perform at VO2 max, which VO2 max means they are extracting as much maximum amount of oxygen as they possibly can. Those horses, so like a racehorse at peak speed, they are operating at VO2 max. They will be dramatically affected by very small reductions in airflow. So it's a big deal for racehorses, probably top event horses on cross country, and maybe some top show jumpers, but 90% of the rest of our equine athletes are not going to be severely affected from like not having enough oxygen to do their job. There may be some other things that will happen with airway restriction for them. Let's see. So this is just some pictures of some airway abnormalities. So over here, this is a left laryngeal hemiplegia. So our quote unquote roarer is what you'll hear the lay term for it. Over here is the normal right arytenoid. So, you know, on both sides, the larynx should look like this. And then this is the epiglottis in its normal position. This left laryngeal hemiplegia, just basically there's the nerve that goes to it is kind of dead, and it's common. It commonly happens in horses. It's just a nerve that commonly gets degenerated for whatever reason. And so they can have various degrees where this arytenoid doesn't open. So because this one is paralyzed, basically it doesn't open wide enough, that's going to reduce the airflow through here. They'll make a noise. Again, usually for most of our performance horses, it's not going to cause them a problem. It's a big problem for race horses though. So you know, you may find this if you hear a noise and you have your horse makes noise, especially at the canter, and then you have them scoped and you see this, chances are you're not going to need to do anything about it. Some of the other things that can happen right here, this is the dorsally displaced soft palate that we were talking about. Oops, we're going to watch this video, but not right now. The dorsally displaced soft palate, this often when they cough. So this might happen a lot to a horse that has lower airway disease, like allergies or heaves in their, or inflammatory airway disease in their lungs. And that sort of chronic coughing may cause them to displace their soft palate a lot. And then that may get them coughing even more. I've had a horse once that was a little bit of a chronic choker, and he did this kind of a lot. So there is a surgical correction for this. Again, you know, you have to do your pluses and minuses of being invasive and doing surgery to correct this versus trying to treat the underlying problem, which may in fact be the lower airway disease. And then over here, this horse's epiglottis is just entrapped inside its soft palate. So rather than just being stuck and kind of sucked underneath, it's stuck within there. And again, that's uncommon in sport horses, usually more of a racehorse thing. I'm going to play this video because there was no real way for me to explain what pharyngeal collapse looks like, I think, without watching a movie of it. But basically up here, this area here is the pharynx. And so if the horse really starts to, you get a lot of negative pressure up here in the pharynx, like they're really, let's say they have some other airway restriction in the nostril or something, or think about a dressage horse, an upper level dressage horse that's in a deep collection and has a very closed throat latch. And maybe that horse is also a bit on the chunky side, which is common. Those horses will get pharyngeal collapse. And I do think they can be symptomatic. This can really only easily be diagnosed with like a treadmill endoscopy. Like this is something that happens at work, not at rest. So there are a few new ways of doing scopings where they actually tie the scope onto the horse's bridle and put it in their nose, and you can ride them around with the scope in. And they call that a dynamic endoscopy. That's kind of how you would have to diagnose that. But I'm gonna play this video so you can see it. They have the little whinny there.
This is a video.
I'll let this guy talk for a minute.
Trialing. The horse is making abnormal respiratory noise. As you can see here, the horse is breathing normally. We now start to occlude the nostril to make it breathe harder. And as you can see, the roof of the pharynx is collapsing, and also the soft palate is starting to billow upwards. So normal airway, and then as we occlude and the horse tries to breathe, there's a collapse. This will result in the horse having restricted airflow. So we can see again, as the horse starts to panic a bit, and due to occlusion of the airways, we lose a normal airway. So this is just in slow motion now here. We have a normal opening of the airway. We can see straight down into the trachea straight ahead of us, with the epiglottis in the normal position. Now as the horse tries to breathe in with the nostrils occluded, you can see that the airway closes right over and the horse is restricted from breathing. Horses with this condition will often perform below their ability and never meet their full potential.
So that he's talking mostly about racehorses in that scenario. Again, I think that our sport horses have a higher tolerance for this, but it could become a problem in an upper level dressage horse. Maybe losing some weight can help that a little bit, but it may be an anatomical variation. And if they panic, if they have to sustain a lot of work in that position for a long time and they're collapsing, they may just say, I don't want to do this, I can't breathe, so that I think that's potentially a thing. So other upper airway abnormalities, you can get these cute little atheromas. It's the cyst of the false nostril, usually pretty easily treated. Sometimes you have to inject them with some formalin or something like that. They're also technically benign and cosmetic problems and don't usually cause any bigger problems. But if you ever had a horse that had a little lump inside the nostril, chances are that's what it is. It's a false nostril cyst or an atheroma. This is an ethmoid hematoma. I thought I was going to get a picture of a normal ethmoid in there, but basically up in the nasal path, I think I forgot to put the normal ethmoid in there. If you've ever seen your vet give your horse a bloody nose when they're tubing them, so they bump into the ethmoids, it happens. It's not a big deal. It's just a very friable area, but there also can form masses there. So nosebleed that doesn't stop, that doesn't go away, especially coming out one nostril, that's a rule out for that. You need to scope them and look to see if they have that. That's just a little tumor that grows there. And then they can get other problems inside the sinuses. So when we talk about the teeth, we're going to talk about tooth root abscesses again, causing infection that come from the tooth roots up in here. But they can also have like a primary sinus cyst, just sort of like this cyst that's growing here, just in the skin of the nostril. They can have a cyst growing inside their sinus. And that's a big cause of head shaking that is not trigeminal neuralgia, that is actually, can be underdiagnosed, and these horses suffer in silence for a while, complaining about their head, shaking their heads, uncomfortable in the bridle, just weird behaviors, head shy. And then, oh, lo and behold, when you actually look into it and work on diagnosing, you'll find out that that's what they have. They have a congenital sinus cyst, and it can be cured with surgery, and then they'll do much better. So it is worth doing some diagnostics sometimes, even though it's not always easy or straightforward to diagnose things in this area. All right. So now we are getting into the teeth. So gastrointestinal system basically is going to involve the dentition, which are the teeth. Horses have, I think the number's 44 teeth. Don't quote me on that. I should know that, but I should have known it for this talk, but I think that's the number. They have, now I'm gonna question myself. 6 and 6 incisors, upper and lower. They can have paired canines. Generally speaking, mares will not. Sometimes you'll see a mare with canines or just little teeny tiny canines. Geldings will often have them. The canines don't really have much of a function. The incisors are meant to be ripping and tearing grass from, that's how they basically eat their grass. Those are tearing and biting teeth. These don't really do anything. They don't have a function. What I will see, so the canines also erupt later in life, so maybe closer to 6 years old. A lot of horses will go through a stage as these canines are erupting where they're very sensitive, and so that's the time that you don't want to drop the bit in their mouth, because they'll start pulling back and not want to let go of the bit. They have that moment happen. And I think I see that a lot in the around 6-year-olds, when these are just starting to erupt and they're very sensitive. Then you have your cheek teeth. If you're going to have a wolf tooth, it's a vestigial tooth that lives right here. And that, again, because this is basically where the bit will live, oftentimes, or when in contact, it can touch here. So we tend to remove those when they're young. And then we have their first premolar. So that's actually the first premolar. This is technically the second premolar. Third, 6, 7, 8. Okay, and then we have the 3 cheek teeth, the 3 molars back here. So this is the 09 tooth, the 10, and then the 11. So there are 6 cheek teeth on the top, 6 cheek teeth on the bottom, and with various entries into the rostral and the caudal maxillary sinuses. So that's not important for everybody to know which tooth is what, but the important thing is to know how long these tooth roots are. They're very, very long. These teeth are continuously wearing throughout the horse's life. So they're chewing and they're grinding and they're wearing their teeth down, and they should ideally be doing it at an even level and evenly across the arcade every year. And then these roots will continue to erupt. And then eventually, you would like the teeth to outlive the horse, but sometimes that doesn't happen and the horse outlives the teeth, and then they need to go like on a pelleted diet or something like that. If you have a dental abnormality and the horse needs to have the tooth extracted when they're very young, it's often more complicated because there's so much more tooth and so much more tooth root that needs to come out. So that's an important consideration. Then we also have like the muscles.
Heather, I'm going to interrupt you very briefly.
Sure.
Let you take a deep breath while Mary does the drawing for the gift certificate from Trafalgar Square. Trafalgar Square has been a sponsor of Dressage for Kids, I think, since 1999 when we started. And I also forgot to mention that the Connecticut Dressage Association is a sponsor of this whole program. So Mary, are you there?
I'm here. Suzanne Weed.
You have to be here in order to get your little gift certificate.
Here. So
Suzanne?
Let me see if I see anybody waving.
She's not yelling, so why don't we go to the next one?
Yep. Audrey? Audrey Pano? Okay, I think I see her on the call. So Audrey, I will send you an email after we're done. Okay, we should be all set. And then there are a couple questions in the chat, so I don't know if you want to address that now or
You know, I
after.
think I'm actually almost done, to be honest. Oops, hang on, let me go back. I think, yes, I think I'm almost done. So if we want to just maybe cruise through the rest of this and then we'll go to there should be time for questions. So anyway, a lot of boring stuff about all the anatomy of it. There's various muscles of mastication. So that's like the big masseter muscle, that's the jowl on the side of the horse's mouth. The temporalis muscle, that's kind of like their forehead muscle up there. And then there's this internal pterygoid muscle that's going to be part of the chewing muscles as well too. Then the TMJ, temporomandibular joint. The anatomy of that is basically it's where the mandible hooks into the top of the skull. Here we can see it a little bit here. There's a little disc, just like a meniscus in the stipple or in your knee. There's going to be a disc in the middle of that can get damaged. And then there's ligaments and the muscles. Again, these muscles of mastication, the masseter and the temporalis muscles are also stabilizing this joint. And then the tongue and the hyoid apparatus are also involved here. We talked about the hyoid when we talked about the surgery to correct the silohyoid fracture, that there's a muscle there that connects the hyoid bone, which I don't have a picture of that here, to the base of the tongue. And so, you know, just being aware that those are connected. The hyoid and the throat and the tongue are connected to each other. So I'm going to show this other little video of the normal chewing cycle, just so you understand how your horse chews. Basically, the jaw will open and the mandible will move sideways relative to the maxilla. Then it will come back up as it closes, it goes back towards the neutral position. And then there's this grinding power phase. Let's see if I can play that again. Where the actual chewing happens. So some horses will chew only in one direction and they can wear their teeth a little bit more abnormally because of that. Oftentimes they'll do that if there's a painful issue or there's a problem but then some horses just chew in one direction as well too. So, you know, there's a little bit of a variation of normal there. And if the horse has a good sedated oral exam and we look at the table angles on both sides of the mouth and what's going on in the mouth, we may be able to try to determine, is there a problem on one side versus the other? The normal wear of the teeth, they will form these enamel points. So this picture is showing what a sharp enamel point looks like. So as they're doing that chewing cycle and they're grinding the teeth down, wearing the teeth down, they will form these sharp points on the outside of the upper teeth. And then on the inside, I couldn't find a good picture of that, but you can sort of see that next to the tongue on the lower teeth, though that's where the sharp points will form normally on horses on the lower. So the outside of the uppers, the inside of the lowers. So this is these sharp points, as you can see, it's cutting and ulcerating to this horse's cheek. Now you strap a crank noseband around and push all that soft tissue against these sharp points, and that's going to hurt and that's going to cause discomfort. And then we all know if we use a little too much hand or our signals are too strong, the horse goes against the hand, they're going to try to open their mouth to get away from it. Now they're really pushing into these sharp points. That's going to cause that can make a horse rear bolt, can cause all of those behavioral problems. So this is an important thing to rule out if you're having a behavioral problem. It's just the first place to go. Just make sure they're comfortable in the bridle, their teeth are well floated, and that has been eliminated as an issue. The hard part is that you can't see what's going on in there. So I am a firm believer that horses need to be sedated in order to get a proper oral exam. Maybe there are plenty of floaters out there who have good technique, and maybe they can do a great float without the horse being sedated. But I am pretty convinced that you cannot do a good, thorough oral exam where you actually get in there with a bright light, looking all the way in the back and truly diagnosing, what's going on in there without a still compliant patient that's allowing you to, get in there and really look. So a lot of times the front molars, the ones that you can see easily, where you can run your finger in there, they may be super floated, nice and smooth, and then way in the back you have a lot of this going on. I see that a lot. So that's just my plug for the good sedated oral exam. Let's see. Going next. Oh, so this is just to describe some of the abnormalities you can find. You can get a big old hook like this in the front. So if they have like a little bit of a malocclusion, an overbite in front, they'll get a hook in the front and then a ramp in the back. The lower tooth on the back will be high as well too. You can get excessive transverse ridges, so like this. So see how the chewing side of this mouth doesn't line up at all, because there's just high spots and low spots within the arcade because they're not lining up and grinding properly. And then they can get also a wave mouth where there's, the whole arcade is just eroded because of high points and low points, basically. This was a very interesting study that was done in Finland, actually, where they did inspections on horses as they were coming off of cross country. This is all bitting and bridle related trauma to the oral mucosa of horses in competition currently. And this is just like a couple of slides from that paper. Like it was pretty dramatic. So, and I've seen it with very good riders. I've seen it with good tack. Like this is like, I think, a trust in a sense bit that shouldn't be bruising anything, but it is, so you just have to look. Like the corners of your horse's mouth are very easy to look. So a lot of times you'll see this hyperpigmentation. That's just from rubbing and irritation there. It may be that the bit's too wide or the mouth is too dry or something. My mare was super sensitive, and every time I changed her bit, she would get one of these little rubs, and like it didn't matter if I barely touched her or not, she would get one of these. Bruising on the bars, I think, is a little bit more dramatic. I don't know if I have a good picture of that in here, but can't quite see. But these are things that can happen. And so if your horse all of a sudden is acting weird, try to peel the corners open, try to take a look, try to get in there and see, because a lot of times they have a good excuse. I personally like these little rubs here. I like to get some Manuka honey and just kind of smear that into the corners of their mouth, and that will help heal a lot of these. Sometimes you just have to get the bit out of their mouth for a while though, until it heals. Because we all know what it feels like to have a chapped lip or a cut on your lip or a canker sore. It doesn't feel good, and this is super common. Shoot, there we go. Super common to find. Oops, hang on, I went too far away. Okay, so yes, these are my last two slides here. So this is just sort of like talking about some of the other things that we like to talk about a lot, like the TMJ, a horse that has TMJ. I think TMJ is diagnosed more commonly by owners and like body workers, massage therapists than veterinarians, because true veterinary pathology of the TMJ is actually quite rare. I think a lot of horses definitely hold a lot of tension in their jaw. And the next slide I'm going to show is the pole. So I think the pole in the jaw is a huge place where horses hold tension and show symptoms, but I don't think that it's very uncommon for them to have primary pathology. So this slide here is just showing what I was talking about, like a really abnormal table angle, where this one is pretty normal flat. And then this is what we call a shear mouth. Like it's just, these teeth are wearing such an abnormal pattern. That would be like a horse that has a bad TMJ, a severely bad TMJ might end up with a mouth that looks like this. This is a CT scan of a horse that got kicked in the head and fractured the TMJ basically. So that's, that's a cool looking slide. And I found that and I thought that would be interesting. But again, CT scan for all of the things we've been talking about is going to be the gold standard diagnostic, because so many of the bones in the head overlap and they're very difficult to diagnose with just a straight x-ray. So CT scan can show us a 3D rendition of things and maybe the way that we need to look to try to diagnose some of these things. A horse that truly has pathological TMJ, though, it can cause really dramatic symptoms. So head shaking, again, another cause of head shaking, bolting, bit avoidance. Another symptom might be this abnormal wear pattern of the teeth. And again, unusual cause, really, but when it is a problem, it tends to be significant and the symptoms are dramatic. The same with the poll. So nuchal bursitis, again, maybe more diagnosed by non-veterinarians than veterinarians, but it doesn't mean that it doesn't exist. They can certainly have inflammation there. This is a picture of a wildly inflamed bursa. Usually you don't get to see anything this dramatic, but basically the nuchal ligament attaches to the base of the skull back here. I look at a lot of x-rays from Europe and I see a lot of young horses that have a lot of bony proliferation at the back of the skull. I don't know how significant it all is because it's so common, but to me, anytime I see a ligament attaching to a bone and then a big bone reaction, that tells me that tried to tear off a little bit, so whether that's over collection in a horse's when they're too young and they're not strong enough to hold that, or trauma, or some weird variation of normal that doesn't really mean anything. I don't really know, but that will commonly see a bony reaction here. And then, but when we see fluid like this and angry bursa like this and some mineralization, dystrophic mineralization there, and true pathology, that can be a real problem. And again, something else that can be diagnosed in a horse that's showing symptoms: head shaking, tension, over and over and over again. All the things in the head can cause the same things. But again, I want to reiterate, we have to look at ourselves and our own riding and our own tack and everything else that's going on with a horse first, but that's not to say that there's never a problem here. So there we go. I made it to the end, and definitely we have some time for questions, barely.
Wow, that was amazing, Heather. What a lot of information. We do have a couple of questions.
Yep.
One is about string halt. Is it considered neurologic? Does it relate at all to shivers?
So string halt, yes, it's neuromuscular, and so it is not related to shivers. It's a different thing. So that's basically going to have something to do with your extensor tendon behind, and it's got its own characteristic sort of pattern. A lot of times it might be trauma to the front of the hock can cause a horse to start having string halt like symptoms. There are in Australia, there's like the false dandelion, there's a toxicity that will cause it. So not entirely the same as shivers. Shivers has its own sort of set of things, and they look similar, but have a different mechanism.
Okay. I'm going to read this whole question. For a horse with diagnosed TMJ trouble, besides chiropractic injections, etc., any recommendations that the rider can do themselves, or recommendations for bridle fit to help alleviate the trouble?
Well, I think anything that sort of works for like muscle pain will be helpful. So I'm a big fan of that people should learn. I like the Masterson method of sort of tension release. I've kind of played around with it myself. There are a few good techniques that I think you can find the videos on for relieving some TMJ pain, and I do think that works. Again, assuming that there's like enough mobility there. So if the horse has a truly arthritic TMJ, they may not have much mobility. I also I recently invested in a class 4 laser, and I've had really, really good results for pain relief with that. So that's more of a veterinary tool. It would be worth looking into if you had a serious TMJ horse to try that with. I'm working on one right now, and I don't know that he has diagnosed TMJ. Actually, I'm like hoping that the owner is going to let me do a full workup on him, so I can look for all of these things and try to figure out exactly why he's so defensive in his pole and his TMJ. That horse, will tolerate me helping him a little bit, and then he's still so very head shy. So it's complicated a little bit, because if they really have a problem there, they may not. They're going to be a little bit defensive. But even like a class 3 laser, I think potentially could be helpful, and that's something that owners can have and work on it a little bit. And then for bridle fit, I don't know that the bridle is going to help so much, but in theory, a thinner bit. You don't want a thick bit on a horse that has TMJ pain, because you're going to like sort of be holding their jaw open. So in theory, you'd want to be reaching for a thinner bit, so that that might make it more comfortable.
Okay, I'll also read this question. I've heard that the tongue is connected to important muscles at the base of the neck, and tension in one can lead to tension in the other. Have you encountered anything like that, especially involved with teeth grinding?
Well, like I was saying, the whole hyoid apparatus is connected to the tongue through that serratohyoid muscle. So yes. But again, this is something that's more common amongst the body workers and the lay workers, that they like want to reach in there and like adjust the hyoid by yanking on the tongue or doing some manipulation with the tongue. I mean, again, you have to be very careful about that, because you can definitely cause damage if like somebody goes in there to futz around with the tongue and then the horse pulls back. You can absolutely cause serious problems with that. I just think anytime a horse has tension in a muscle group, it's not good, right? Like, we don't want our horses to be tense and holding tension. So how one group is connected to the other, is it the tongue? Is it, are they grinding? Are they unhappy because they have a tense neck, or they have a tense neck because they're unhappy? So I think we owe it to ourselves to be honest and try to figure out, like, how do I bring my horse back to a place where they're just not tense all the time? And how do I keep them relaxed? How do I keep them happy? I mean, we're all trying to do that because we all love our horses, but you know, yes, there may be a veterinary cause, and it may be in the head, it may be in the neck, it may be in the tongue, but it also may be completely somewhere else, unfortunately. And that's just where they're showing it to us.
Well, I think that's all the questions. All the thank yous are coming in now, Heather. That was really, really well done.
Great.
Okay, I'm sorry. Wait, Mary just texted me that a question came to her. Opinion on how to choose the right body work for your horse. There's a little tiny question.
Oh, geez. Well, I mean, so I think I'll put a vote for veterinary medicine here. I think that like the body worker should be working in conjunction with your veterinarian. And I think your veterinarian should be open and willing to work with your body worker too. You know what I mean? I think that everything has its place. And so, and I don't think it should become like a turfy thing. I think it should be complementary. So, I like it when can I talk to somebody that's working on a patient of mine, and they say things and then it makes sense and it fits with how I know of the horse. So you can always ask your veterinarian, hey, the body worker said XYZ about my horse. Does this make any sense? And if it does, like for me, if I go, yeah, your horse totally gets tense there, and if you see an improvement after they work on your horse, great. Like that's going to help maintain in between my visits, because I don't like poking holes in horses. I don't like injecting them over and over and over again. And that's kind of what I can do as a veterinarian. Like the tools and the things out there are advancing so much that we have other things that we can be doing too. But at the end of the day, to maintain the athletes and to keep them happy, sometimes they just need a little muscle work, and is really, really helpful for them and beneficial. So I would be wary of somebody who says that they can fix it all, they can diagnose it all, that starts to like make all these big promises and things like that. But somebody that's willing to work with your veterinarian, that's open and listens to you, and that your horse feels better after they work on them, and that your horse enjoys it, I think that's all a good sign.
Okay, I don't know if you can see the chat, Heather, but there's lots of thank yous coming in in various ways. I hope you can catch that. And again, a thank you to Connecticut Dressage Association and Trafalgar Square for their support of this program, that both of them have been doing that for many years. So, and you all see Heather on this last slide has left you with her email if anyone has other questions and wants to contact her. And thank you very, very much.
All right, have a good night, everybody.
Good night.
Take care.